All right. Hello and welcome to Noon Conference hosted by MRI Online. In response to the changes happening around the world right now and the shutting down of in person events, we have decided to provide free daily noon conferences to all radiologists around the world. Today, we are joined by Dr. John Carrino. Dr. Carrino is an internationally renowned radiologist with particular expertise in diagnostic imaging and percutaneous image guided intervention. He is a co author of over 200 peer reviewed publications in a variety of areas. A reminder that there will be a Q&A session at the end of this lecture, so please use the Q&A feature to ask your questions and we will get to as many as we can before our time is up. That being said, thank you all for joining us today. Dr. Carino, I will let you take it from here.
Thank you. May I get an audio check? Can you hear me okay?
You are coming through loud and clear.
And a visual check? You can see the
Yep.
slides okay?
Excellent.
Great. All right. Well, hi, it's John Carrino. It's certainly my pleasure to participate in this forum. And I want to thank Dr. Janet Collins for inviting me. And today we're going to talk about a practical topic, interpreting lumbar spine MRIs, and really kind of distilling out what are the features that are relevant that radiologists should be looking for and should be commenting on in their report. So our objectives for this lecture is to learn which lumbar spine MRI findings are more reliable indicators of pain generators when imaging symptomatic populations and patients, to understand the issues with oversensitivity of spine MRI with the quote-unquote degenerative findings that are often present. And 3 is to understand the issues for lack of specificity of spine MRI, particularly when imaging patients in a non-load-bearing state, which is typically done or most commonly done with our current install base of MRIs where the patient is laying supine. A little bit about low back pain epidemiology. So about 2/3 of the population will have some episode of back pain at some point during their life. While most acute back pain resolves within weeks to months, surveys report that approximately somewhere between 5 to 10% of the population has chronic back pain. And this has implies significant social and economic impacts. The risk of low back pain in general increases with age. And those affected can have disabling symptoms that can dramatically affect their quality of life and ability to perform a variety of activities. So in terms of pain characteristics, we can separate pain based on duration, acute versus chronic. We can look at location, low back pain versus sciatica or radicular pain or leg pain, and then talk about the associations, the so-called red flag conditions. So in terms of duration, back pain may be classified according to the length of time. And according to the International Association for the Study of Pain, acute is less than 6 weeks, subacute is in our 6 to 12 week range, and chronic is greater than 12 weeks. This is significant because the biology, pathology, natural history, and evidence base for each class of back pain can be distinctly different. So in terms of imaging in the acute presentation, there's been a number of studies, and this is a meta-analysis that Roger Cho and I was able to participate in with Roger, looking at imaging strategies. And it was a meta-analysis of randomized controlled trials comparing immediate imaging versus clinically directed care. And it was determined that no significant differences in pain or function in the image versus the non-imaged patients, looking at short, that is 3 months, or longer term, 6 to 12 month outcome. So lumbar imaging for low back pain without indications of serious underlying conditions doesn't improve the clinical outcomes. There are other studies looking at the value of information. Sometimes knowing what the imaging is early on can actually be a bit deleterious to patients if it's not expressed appropriately, because we often see abnormalities or degenerative findings. And if they're not educated about that, they feel that they are now labeled with a condition, which could impact their course of improvement. So what are the red flag conditions that were mentioned? It's a term that refers to the clinical or physical features indicating the possible presence of a serious but less common disease requiring more specific evaluation and treatment. So these conditions include things like a neoplasm, infection, fractures, other trauma that might include neurological damage, so things that can herald with neurological symptoms. So in terms of imaging, a technique like MRI is really exquisite for detecting these red flag conditions. So looking at some of the underlying diseases such as tumor infection, spondyloarthritis, fracture. However, these are not the most common conditions. So if we're looking at people presenting with back and leg pain, 0.7% will have metastatic neoplasm, 0.01% will have an infection, about 4 or 5% will have a fracture, like a compression fracture, often related to osteoporosis, but sometimes related to neoplasm, or an inflammatory spondyloarthropathy in a fraction of a percentage. So this low prevalence of so-called or quote-unquote systemic disease or sinister conditions implies that most of the findings we're going to see on routine spine imaging done for pain will be degenerative in nature. So there are specificity faults or issues and sensitivity issues. So remember, specificity is negative in health. So degenerative findings are seen in non-symptomatic subjects, and they're often correlated with aging. Degenerative findings are noted in populations in excess of the disease, that is the back or limb pain prevalence. So that means MRI should not be used as a screening tool, to try to screen people for abnormalities. There are also sensitivity issues. Remember, sensitivity refers to positive in disease. And so MRI can be insensitive to certain dynamic lesions, such as instability or spondylolisthesis. We'll talk a little bit about that. And then what about the validity or usefulness? Can imaging predict a clinical course? In general, no. So I can't look at an MRI image and say to somebody, you're going to do well, you're going to do poorly. There are some things that help with the prognosis, but even large disc herniations will in general have a better prognosis, contrary to what someone might believe. And then can imaging predict a response to therapy? In general, the answer is no. So imaging is there to confirm a pretest probability, so evaluated by a spine specialist, preferably, and that person identifies that we're concerned about a disc herniation, and then imaging can confirm that and potentially direct therapy, such as an injection or surgery. Now, this slide just shows there are a number of studies. These are all studies that were done on non-symptomatic populations with a variety of modalities. And the couple of columns that I would highlight is that if you look at the column of disc degeneration, you can see that disc degeneration can be identified anywhere from 20 to 90% of the population on the different imaging exams, depending on the subjects you're looking at and the definitions utilized. Disc herniation also has a fairly high prevalence, so anywhere from, again, 20 to 75%, depending on who you're imaging and how you're defining it. So when we think of pain of spinal origin, again, we'd like to separate it into axial and radicular. So axial is central in distribution, often poorly localized. It has more of an aching or dull character. It can be precipitated by motion, having kind of a mechanical component to it, and may be relieved by activity. Radicular pain radiates often in a narrow band peripherally. It can have this sharp electrical character, it can be lancinating. It may be precipitated by weight bearing, may be slightly worsened in extension, because that tends to worsen things such as neuroforaminal stenoses. It's often relieved by recumbency. And to separate radicular pain from radiculopathy, so radicular pain refers to the sensation you have, this kind of lancinating, shooting pain. Radiculopathy refers to dysfunction of the nerve. So the nerve can have a sensory dysfunction, so different, paresthesias and dysesthesias. You can have a motor dysfunction, particularly ones that are innervating the muscle, where the muscles are twitching or getting weak. You can have tendon reflex deficits. So radiculopathy is a sign that the nerve is getting damaged. Radicular pain is something that is potentially treatable by things like injections or other pain medicines. And radiculopathy is typically what the clinician is concerned about monitoring, so as that there's not a worsening neurologic deficit, or they're going to be losing nerve function that's not recoverable. So when we look at axial pain generators, and the reference standard is typically using injections, so whether they're anesthetic pain relieving injections or provocative injections, those are the reference standard that's used. And so here's a nice summary, a nice report that also is concordant with the rest of the literature in this area, that we find that for chronic axial pain, the disc is the source in about 42%. The facet joint, which is also known as the zygopophyseal joint or Z joint, particularly if you're working with pain management clinicians or physiatrists, that's often the term that they use. And that's 31% of the time is the facet joint, whereas the sacroiliac joint or SI joint is about 18% of the time. And then the remaining proportion is made up of these, again, more sinister conditions such as fractures, posterior element apposition such as Bastrop disease. So when we're looking at patients with axial pain generators over the age group, so these four graphs show the proportion contributing to axial pain versus age in years. And so patients with discogenic pain are significantly younger than patients with facet or SI joint pain. As one increases in age, the probability of the disc as a pain generator decreases, and the probability of a facet or SI joint increases up to approximately age 70. And then, of course, there are other causes thrown in there, such as neoplasm, infection, fracture. Let's talk a little bit about the disc. So the discovertebral complex has a central nuclear compartment. It's made up of a mucoid matrix. It can deform under pressure. It helps to distribute the load axially, the axial compressive load radially through the disc. There is an outer annulus fibrosus made up of concentric rings of collagen fibers. It restricts this radial movement, constrains the expansion of the nucleus. There is a cartilaginous end plate, which is basically the biochemical and nutritional interface between the disc and the rest of the body, because it sits between the disc and the bone marrow, which is highly perfused. So it has collagen fibers continuous with the annulus and enclosing the nucleus, but it is composed of hyaline cartilage. So in terms of our MRI sequences that we typically use for spine imaging, it's often our routine T1, T2, and you should always have a fluid-sensitive sequence such as inversion recovery, STIR, or T2 FAT-SAT. Again, that's the STIR is to pick up a bright signal that may be related to things like infection, fracture, or neoplasm, but can also be helpful in some degenerative conditions, as we'll talk about. So when you look at a spine image or any image, you look at a fluid-containing structure, and here we have the cerebral spinal fluid, which is dark. So this is a T1 weighted image. The fat is bright, so we typically do not use fat suppression with our routine spine imaging. Here we have a T2 weighted image where the fat is still relatively bright, but now you notice the fluid, the CSF fluid is bright. And so this denotes that there's a T2 component. to it. Many places do it without fat suppression, so you can see an area of the architecture, the discs, and you get a little bit better spatial resolution. And then in terms of improving fluid conspicuity, doing a fat suppressed thing like a stir, which is a combination of T1 and T2, so fluid tends to be especially bright. It allows you, again, to pick up some of these other pathologies and really feel it's a mandatory part of any imaging protocol that you use in the spine. So here's just an example of what a normal lumbar spine would look like with relatively fat bone marrow, the disc, which we'll talk about the disc architecture that's relatively bright, and the CSF fluid that's bright, and then our subcutaneous and retroperitoneal fat that stays bright on the T1 and T2 sequences. And then in terms of axial images, some places use T1s and T2s. I think the T2 weighted axial images are more revealing, especially for disc pathology. Issue becomes, do you do them at every disc level or do you do them in a stack? And when we talk about disc herniations, the American College of Radiology recommends you do at least one series parallel to the intervertebral disc that you're interested in to best identify the contour abnormalities. Now, I'm going to show a number of grading systems here, not that we use them clinically. They're often used in a research context, but they are helpful for kind of understanding what happens. So this is one of the number of grading systems that has been developed in the spine. So for this disc grading system, we go from the top, from A all the way down to E, which corresponds to the numbers on the left, 1 through 5. And so A at the top is a normal disc. It's a bright nuclear center. It's got a dark annulus fibrosis. Again, annulus fibrosis has no free protons, so it's going to be dark on all pulse sequences normally. The nucleus pulposus has a water binding capacity, and that brings out the T2 signal. B is where you have a fibrous cleft in the center of the disc, which is basically a normal variant. As one gets older or more mature, we go to C, where the nucleus pulposus has now lost its water binding capacity and it becomes more gray or darker. You may lose the nuclear annular distinction, as we see in D, where we have a completely a dark disc. That may also occur with some concomitant disc height loss and some disc contour abnormalities such as bulging. And then E is the bottom, is an end stage disc where basically your disc space is collapsed or near collapsed. You have more of the osteophytic ridging and bulging that's occurring. So looking at these discs, in terms of identifying which one is a potential pain generator, it would be really challenging based on the feature, just the features here. What we can tell you is that A and B are not pain generators. So normal looking disc is not typically a pain generator. And also my experience, E, an end stage disc, because by that time you're almost auto-arthrodesed or fused. There's not much motion there. You don't really have the instability phase or inflammatory changes that you get with degenerative disc disease. So it's really kind of the C and D categories, which I would consider an indeterminate disc, whether in terms of considering it a pain generator, that is a nociceptor. So when we think about disc age-related change or degeneration, we talk about this so-called dehydration effect. There's a water content in the disc about closer to 90% in early childhood, but greater than less than 70% by the 8th decade. And this physiologic change in the biochemical composition of the disc matrix is what's reflected in that water binding capacity that we see on the T2 weighted images. So this decreased water also goes along with decreased height and a diminished ability of the nucleus to dissipate the axial load. And so there's increased load burden of the annulus fibrosis. leads to osteophyte proliferation and helps to distribute the axial loads over a wider area. And these findings tend to be ubiquitous. There is some genetic component. It does correlate with age, but not with pain. So again, degenerative in that it describes physiologic degeneration that typically occurs naturally with age in people with a genetic predisposition, and not necessarily pathologic. So as we look at images here, sagittal T2 weighted images going from infant to young adult to an older adult, we can see these age-related changes as I showed you in the previous disc classification scheme. However, if you're presented with a young adult, such as the 26-year-old male on the right, and we start seeing these changes, what we would call kind of premature degenerative changes for someone of this age, then you can implicate them into pathology because that shouldn't have occurred by this age. So in terms of chronic low back pain and degenerative disc disease is a morphologic description of this age-related changes that shows no association with pain. And therefore, when you say somebody has degenerative disc disease, it doesn't constitute a diagnosis of back pain. So now we're going to switch to this other concept of internal disc derangement, which came about in the 70s. It's a specific condition distinct from degenerative disc disease. It's characterized by degradation of the matrix of the nucleus pulposus. There's fissures that penetrate the annulus fibrosus without breaching the outer lamina. So these contained fissures tend to be the more painful ones. It has a mechanical etiology implicated from fatigue fracture of the end plate. And the affected discs exhibit specific biophysical and biochemical features that do correlate with the disc being painful on discography. So you have a large axial load or repetitive loads this, causing fatigue and end plate fracture. There's an inflammatory response to fracture and/or exposed nuclear matrix, which has a lot of inflammatory mediators. The nuclear matrix undergoes degradation where there's depressurization, height loss. Axial load is now more assumed by the annulus, particularly the posterior annulus. This can lead to annular failure where you have radial fissures constituting this internal disc derangement. The fissures that reach the outer annulus can stimulate a granulomatous response, and then pain generation can ensue because of mechanical stimulation of outer annular innervation. So this granulation tissue brings in unmyelinated nerve fibers. There's also chemical sensitization, so pain with minimal increase in axial load. And then there's amplification of acquired innervation in these fissures as that granulation tissue comes in. And so schematically, we can grade them. You can grade them as low grade, just in the inner annulus, middle annulus, or going toward the outer annulus, such as in grade 3. And these often have a radial configuration. Grade 4 is showing more of a circumferential configuration. And so when you get to that outer annulus, they can also spread circumferentially as well as radially. So innervation is typically of the outer third of the annulus. Grade 1 and grade 2 are seldom painful. It's the grade 3 and grade 4s that are often painful. So about 70% of painful discs will have these grade 3 radial fissures at discography. And about 70% of discs with grade 3 radial fissures are painful. So again, it's highly correlated or associated, not perfect, but higher than high enough to be useful as a marker. So now we need to understand what the MRI correlate of this is. So when we're imaging the diagnosis of internal disc derangement or trying to implicate the disc as a pain generator, there are two imaging parameters that are useful predictors. These are end plate changes, the so-called modic changes, and our hyperintense zone, or HIZ. HIZ is not part of the standard nomenclature that's used by many of the spine societies. So annular fissure is a term that's typically preferred or utilized, although this was originally described in MRI as an HIZ or hyperintense zone. So an HIZ is a bright area in that normally dark outer annulus. It originally described as equal to fluid, but it can be, approximating fluid, certainly brighter than the signal void that's typically present there, or that's normally should be present. On T1 weighted images, without contrast, it's inconspicuous. However, if you give contrast material, some of the annular fissures or HIZs will enhance, and the ones that enhance are probably more likely to be painful. We don't typically give contrast to non-operated spine, so we're not always making this observation, but in the studies that looked at it, if you give contrast material and it's enhancing, it kind of ups the ante for that finding. And again, there have been numerous studies looking at this, starting in 1992 and even continuing on today. And here they've expressed it as a likelihood ratio. And I'll talk about the summary of this. So if you look at the pooled data, the likelihood ratio of about 3.8, so corresponding to a 73% probability of a painful disc at provocative discography. So we can state that in a symptomatic population that you're imaging, a HIZ or annular fissure strongly predicts a painful disc. And here we see it on MRI as that bright zone, and then in this case, the CT discogram correlate. So let's talk a little bit about marrow imaging. So there's red marrow, the hematopoietic marrow, and yellow marrow. The signal intensity of bone marrow reflects its underlying composition. However, even red marrow has about 40% fat, and often that fat will dominate the signal. So when we're imaging adults, we can see on our T1 weighted images, we have relatively bright marrow because of the 40 to 80% fat that's present. And of course, this should suppress out on our fat set techniques. So these modic lesions occur in the spongiosa of the vertebral bodies adjacent to an affected disc next to the end plate. There's three types. There's edema signal, there's fat signal, and then there's sclerosis. They do represent a continuum and spectrum of end plate reaction to degenerative disc disease, and there have been longitudinal studies following people over a decade or so, identifying them going from, say, a type 1 to a type 2 and on to a type 3. So modic type 1 is where you have hemispherical signal alteration, or I should say the signal alteration is low on T1, bright on T2. The characteristic configuration is where you have this hemispherical area that's abutting a degenerated disc. It doesn't have to be on both sides of the disc, but it often is. Type 2 will follow fat on your fat sequences, so bright on T1. Now remember, the marrow is 40 to 80% fat, and this looks brighter because it's closer to 100% fat. And again, bright on your T2 without fat suppression. So you can think of this as a kind of a reparative phenomena where you maybe depleted your myeloid elements. So now you have your fat that's looking brighter, a higher proportion of lipid there. And it should suppress out on your fat suppression sequences to help distinguish it from edema. So these end plate changes are often inflammatory in nature, at least to start. That's been shown with biopsies. So with modic 1, you get vascularized granulation tissue, this fibrovascular pathology there. And modic type 2, you can get fatty infiltration. And modic type 3 is this sclerotic or end-stage eburnation that occurs in the bone. So Modic 1 greater than modic 2 represents an inflammatory state. You have increased level of these inflammatory mediators such as TNF alpha. And when you compare it to M plates without the modic changes, and again, this is based on some biopsy work and cadaver work. So modic change, either type 1 or type 2, when it's substantial in size, meaning involving greater than 25% of the vertical height of the vertebral body, very strongly correlates with provocation discography. And so, again, a number of studies looked at this, similar to the HIZ. And when we pool those data, there's a likelihood ratio, again, of about 3.4. And so if the prevalence of discogenic pain is 42%, as we talked about in the earlier part, this translates into about a 71% post-test probability of a painful disc. So the higher the positive likelihood ratio, the more likely it is the patient with a positive test has the disease. In this case, we're talking about discogenic pain. Likelihood ratios greater than 2 are considered useful, and particularly if the confidence interval doesn't cross 1. And so, again, both the modic type 1 and type 2 and the HIZ or annular fissure have a decent likelihood ratio. So as mentioned, there's a strong correlation with the disc being painful on stimulation. Now, there's a low sensitivity, meaning that not everybody with discogenic pain is going to have modic changes or are you able to identify an annular fissure for that matter. But there is a relatively high specificity, meaning that when they're present, they are associated with a painful disc, as we just talked about or demonstrated with the numerous studies, when you're imaging a symptomatic population. Do these findings occur in non-symptomatic patients? Yes, they do. But if they're not symptomatic or they're not being coming in for predominantly axial pain, then it's less relevant. And just to be complete, modic type 3 is a sclerosis, a little bit harder sometimes to identify an MRI because it's a low signal. So it's low on T1 and low on T2. And it's not unusual to have mixed modic findings where we have an area of sclerosis, low signal on T1 and fat suppression, and then which is a type 3. And then on the superior end plate, a type 2, where you have a bright signal, which then suppresses out, representing fat. So to kind of summarize discogenic pain imaging correlates, again, discogenic pain being one of the reasons for axial pain. So in a population for clinically suspected discogenic pain, might be a younger person with axial pain. Normal nuclear signal essentially excludes that as being a nociceptor or a painful disc. When you have these intermediate nuclear signals, a high intensity zone strongly predicts a painful disc. And there have been other studies that in combination with a disc protrusion, meaning a small contour abnormality, very strongly predicts a painful disc. And the modic changes, type 1 or type 2, also very strongly predict a painful disc. So that helps you make a diagnosis. Is this adequate for therapeutic decisions? Well, there's no validated therapy for this to test it against. So let's move on to another cause for axial pain, which is the Z joint or facet joint. So here we have the articulations of the facet is basically the inferior articular process of the posterior elements of one vertebra with the superior articular process of the posterior elements of the next vertebra. And so, facet refers to just only one facet of the joint, so to speak. So that's why Z joint is sometimes used or is more appropriate. It's a synovial joint like a knee or shoulder joint. So it has a capsule, synovium, reciprocating hyaline or articular cartilage, and even small menisci. So the degenerative process of a facet joint is osteoarthritis, which by imaging is typically characterized by loss of articular cartilage, which can be seen as joint space narrowing and particularly in a loaded condition for that joint, osteophytosis, and a subchondral bone reaction, which on MRI will be bone marrow edema lesions and or cysts. Again, there's a grading system. So in this grading system, which we don't use clinically, but helps us to kind of think about the spectrum of OA. Normal facet joint has about a 2 to 4 millimeter width. You can see some cartilage there in a normal architecture. So mild osteoarthritis would have narrowing of the facet joint ideally, and or small osteophytes with mild hypertrophy or enlargement of those articular processes. Moderate degeneration or moderate osteoarthritis would have narrowing of the facet joint, slightly more prominent moderate-sized osteophytes and hypertrophy, and it could have what's called these subarticular erosions, which are basically probably small subchondral cysts. If you put them in another larger joint, that's what you would call them. And then severe osteoarthritis is where you can have narrowing the facet joints. You have these larger lipping osteophytes that occur, more marked hypertrophy, and more prominent subarticular cysts or erosions. Now, in terms of axial pain in the facet joint, about, as mentioned, 10 to 15% of axial pain, more common in the elderly. There's a fibrous capsule of the facet joint that's richly innervated. There's nociceptors that may be sensitized by inflammatory mediators. And the most common inflammatory state, again, is osteoarthritis. So one of the utilities of that fluid-sensitive sequence is helping to identify this area of subarticular bone marrow edema lesion. So similar to a knee joint, where it's been correlated with osteoarthritis, we think of this as a reaction related to degeneration. It does often become confluent with the pedicle. And so when one looks at this, you may think, well, could this represent something like infection or metastatic neoplasm? However, the overwhelming likelihood is that it's degenerative related. So severe morphologic changes of osteoarthritis alone doesn't predict pain, whether it's on MRI or CT. But the subarticular bone marrow edema pattern, capsulitis, if you see either edema or enhancement of the capsule, if you give contrast material, then suggests that this is more likely to be a pain generator. So the data on facet joint imaging is not as strong for these features as it is for the disc. The morphologic imaging evidence of osteoarthritis, again, doesn't have, in general, correlation with pain, but the so-called quote-unquote physiologic imaging can help you identify the facet joint as more likely to be a pain generator. So you can look for T2 hyperintensity, the subarticular bone marrow edema. You can look for capsulitis, either with gadolinium enhancement or on your T2 weighted sequence with pericapsular edema. And if one does nuclear medicine techniques, they may have hyperemia and increased bone turnover. And some people have advocated for that, although it probably doesn't add anything over our routine MRI imaging, in my opinion. All of these findings are conceptually appealing, but they're not validated against the reference standard for facet pain, which are medial branch blocks, where you put an anesthetic on the medial branch and see if that relieves the axial pain and then implicate that facet joint. There's poor correlation between the nuclear medicine techniques and the MRI techniques, which makes it a little bit more challenging. But I think MRI does a reasonable job overall. And if one does suspect facet joint pain, again, doing medial branch blocks are something that's commonly performed to help confirm that. Now, one thing I'd like to mention with the facet joints here is that you sometimes paradoxically see a widened facet joint. So remember, we said OA is loss of articular cartilage and there should be joint space narrowing, but that's in the loaded condition. So here we're imaging somebody in a supine condition. We have the morphologic features of OA with osteophytosis, et cetera, but the joint looks widened or distracted, or there's a gap there. And so when you see this, you should think about a spondylolisthesis with a component of instability or hypermobility. And so this is one of a number of studies and also study that we're looking at, that there's often that I'm sorry, when you look at when you interpret MR imaging, I think it's really paramount to have the radiographs. And when the radiographs of the spine are performed, they should be performed in an upright loaded position. That's one of the advantages of doing radiography. You can do radiography in a loaded state. And here you can see this is the same patient, and there's a very dramatic difference in the amount of listhesis. So whether you use the traditional criteria, greater than 3 or 4 millimeters between flexion extension to help define instability, I find that the difference between the upright loaded radiograph and supine MRI is often more dramatic and sometimes more informative than flexion extension views, where you basically have the listhesis there, and then they do flexion extension maneuvers, but maybe the excursion is not so great, or they've already loaded the joint and they're already put them in that pain position. Whereas doing recumbent versus upright imaging can be very informative. So when I see this, I'll mention that finding and suggest that at that motion segment, there is a component of instability or hypermobility. Just a little bit about stenosis. So spinal stenosis can cause radiculopathy and related neurologic symptoms, but per se, it's not a cause of back pain. We can do a whole separate lecture on neurogenic claudication and venous hypertension and the things that occur related to that, to spinal stenosis. However, back pain may be caused by conditions that also happen to cause stenosis, such as facet arthropathy. And then central canal stenosis is there's often a developmental component with shortening of the pedicles, sometimes narrowing of the interpedicular distance, and then superimposed acquired findings, often on the facet, not so much disc disease, which then reduces that central canal and compresses the thecal sac into a trefoil configuration, which is this Irish icon shown here on the bottom right. Now, we can now segue kind of from axial to radicular pain and think about neuroforaminal stenosis. So neuroforaminal stenosis can be a contributor to radicular symptoms. And so you may have a combination of the facet joint hypertrophy and a disc bulge or disc osteophyte complex, which is really not a standard term either. You often get some disc material that projects into the neuroforamen, related to a herniation or end plate remodeling. And then this can yield neuroforaminal stenosis and cause impingement of the nerve. So now let's move into how we would classify disc contour abnormalities. So this original study in the New England Journal rated things as a normal contour, bulge, herniations, which can be subtyped as protrusion, extrusion, or sequestered fragments. So again, to best characterize disc contour abnormalities, one should put at least one set of pulse sequences parallel to the intervertebral disc. And typically, I think the T2s work quite well for that. So a bulge is a diffuse contour abnormality if you consider the disc as a circle, which it really is not, but greater than 50% or 180 degrees of circumference. So looking at it on the sagittal, you really can't tell if that's a focal or diffuse contour abnormality, but on our axial prescribed at the disc, parallel to the disc space, we see that this is a diffuse abnormality, and we would characterize it as a disc bulge. They can be symmetric, like the one I just showed you, or it could be asymmetric, sometimes known as eccentric disc bulge. A protrusion is a focal contour abnormality where the amount of material that's displaced into the canal is the smallest component. So the base here is broader than the amount that's displaced into the canal. And these protrusions correlate to, again, an annular fissure with a contained annular fissure. The outer annulus pathologically is not disrupted in a protrusion. We can't always tell if that's the case or not, but that's part of the internal disc derangement. So you can have more focal herniations, or you can have ones that are more broad-based. And then when you have a more substantial amount of disc material that's projected into the canal, often, again, related to a disrupted outer annulus, you can then characterize it as an extrusion, so that the largest dimension is the part that's projecting into the canal, whether it's in the AP dimension or in the craniocaudal dimension as shown here. And extrusions are larger. They're more likely to be symptomatic because they can irritate and compress nerves. So here we're seeing this L5S1 left subarticular zone extrusion compressing the traversing left S1 nerve, that basically the axillary sleeve, and it's compressing it against the facet joint. So it's not simply a matter of compression, but there's those inflammatory mediators that we mentioned are then expressed here, and then this contributes to radicular pain. So sometimes the disc material can be sizable amount that's extruded into the canal. This has been likened to stepping on a tube of toothpaste, and so known as the toothpaste sign. But what this actually represents is not only disc material, but the inflammatory reaction that it's set up, and also sometimes a component of hemorrhage. There are some veins around that area, the epidural veins, can sometimes rupture. So if you were to look at the amount of disc that's present in the canal here, and you tried to push it back into the original disc space, you would basically get a supersized or a larger than anticipated disc height. And that's because this is not simply disc material, but also the other inflammation and or hemorrhage. So once a disc is extruded, it can migrate. It can migrate cephalad or caudal within the spinal canal, as shown here. So we have a large disc extrusion with migration. Now, if you see a cleavage plane between the parent disc and the extruded fragment, then you can consider that a sequestered disc. So that previous one suggested it was sequestered. Here, there's some fat between this disc fragment and the native disc. And so this would be considered sequestered. Now, in terms of migration and sequestration, it was previously felt that sequestered discs would not be likely to respond to, say, to conservative or, say, percutaneous therapy, such as a spine injection. That's actually not the case. So again, simply seeing a sequestered disc doesn't mandate surgery, doesn't mean that it has to be treated by surgery. It's because it's the inflammatory reaction and other things around there that is causing the pain, which you would separate from the neurologic dysfunction. So if you're trying to treat the pain, the size of the disc and whether it's sequestered or not, it doesn't really play a factor in terms of giving you a more poor prognosis. So as we talk about radicular pain, it's that lancinating pain that travels in the lower limb along a narrow band. It's caused by a disc herniation, foraminal stenosis, lateral recess stenosis, or other space-occupying lesion in the canal that will compromise and irritate the lumbosacral nerve roots. And again, there's a grading system. Again, I think this one is useful in terms of how you express. So when you're reading an MRI exam, you want to identify that there's a disc herniation or disc contour abnormality. You also want to identify what it's doing to the either exiting or traversing nerves. And this is one of the concepts that Dick Herzog, one of my partners here at HSS, is really pressed into us, and it's very useful. So you can't just say there's a disc herniation. You should identify what it does to the adjacent nerves. So it may do nothing. May be remote from any nerves, not causing any mass effect. It may contact the nerve. So here we see it's touching the nerve, loss of the epidural fat plane, but there's no deviation or distortion of the neural elements. Here, in this grading system, it's known as deviation. Many of us use the word impingement for this. So now the nerve is being displaced by the disc material, but maintains a relatively normal nerve morphology. So something that's being deviated, it's appropriate, I think, to use the word impingement here. And so the nerve is being impinged. And then, as I showed you previously, you could push the nerve up against something, let's say the facet joint in the subarticular zone, as shown here. And so nerve compression between this material and the posterior elements now causes a morphologic alteration. And so this provides a nice grading scheme from normal to contact to deviation or impingement, and then compression. Now, is this significant? Well, at least in this one study and some others, they found that this grading system had a good intra and intra-observer agreement, but also had a reasonable MRI correlation. So as you can imagine, compression more significant than deviation or impingement, more significant than contact. So I think these are good ways to express what a disc does to the nerve, and realizing that we're, again, imaging in the unloaded state. So when person is upright, a nerve that looks like it's being impinged may go on to have more compression or higher grade impingement, and can be implicated as being the pain generator. So for patients who present with first-time episodes of low back pain, are there new MRI findings? So meaning, is it good to have a baseline MRI that we can compare? So this 5-year prospective study looked at baseline MRIs in patients before they were symptomatic. Then they came back when they were symptomatic, and they found that less than 5% MRI showed clinically relevant new findings. Unless it was related to some acute episode, there was unlikely to have a new structural change. And again, only direct evidence of nerve root compression, as I just showed you, with corresponding radicular pain was useful. So again, having concordance between what was clinically being evaluated and what the imaging was showing. We'll talk a little bit about what else can cause radicular pain. So besides disc herniations and foraminal stenosis, we can think of synovial cysts from the facet joint. So these are associated with degenerated or traumatized facet joints. The synovium herniates through the joint capsule. The prevalence is about 2% in the symptomatic population, 2% that will go into the canal and potentially cause radicular type symptoms. They're most common at L4-L5 in 65 to 80%, but also see them at L5-S1 and L3-L4. So basically the mid to lower motion segments in the lumbar spine. They're often associated with some component of spondylolisthesis, even if it's mild. So when you see spondylolisthesis, we see the disc slip, but also think of it as a facet disease. So as you get facet disease, this allows the disc to slip. So there's a 40 to 75% association of synovial cysts with some degree of spondylolisthesis, which again may be more apparent on an upright radiograph. And it can cause radicular symptoms and contribute to things like neurogenic claudication and, of course, low back pain from the facet OA. So typical location is in the lateral recess going into the central canal. Less typical, they can have a foraminal location. And so these ones that are going into the canal or into the foramen are coming from the superior recess of the facet joint. So remember, there's a superior recess and inferior recess. The inferior recess, shown here in the green arrow, go extraspinal. So they're extracanalicular, they're posterior, they usually don't cause symptoms. They're just a manifestation that the person has OA. They're often heterogeneous in their signal characteristics. You can typically identify a connection, or that this synovial cyst is coming off the joint plane in at least one of the sections that you're looking at. And then there's underlying osteoarthritis of the facet joint present. So their signal intensity can be variable. Well, on T2, they can have mixed signal intensity. They can be hyperintense because of the fluid content. They can be hypointense sometimes of mineralization. On T1, they can also have mixed signal intensity because of some proteinaceous material. So they may be natively somewhat bright on T1. They will often peripherally enhance because of the irritation around the capsule. Again, a little bit of capsulitis. And with the low signal may indicate that they're mineralized, so they often can have peripheral calcification. And when they're in the foramen, again, they contribute to radicular symptoms. So they mimic a disc herniation. And here's one that's bilobed with mixed signal intensity in the canal and going into the foramen as well. So it has a chance of getting both the traversing as well as the exiting nerve. So when we talk about the spine imaging, most of what we're doing with MRI is anatomic or morphologic spine imaging. We remember the specificity issues that we have. Imaging demonstrates spinal degenerative findings in anywhere from 1/3 to 2/3 of non-symptomatic persons. Things like bulges, small protrusions, facet degeneration, listhesis is common. They're often not symptomatic or not a major contributor to symptoms, and their prevalence increases with age. Again, annular fissures can be seen in either group, but we talked about imaging symptomatic patients and the high probability or predictive value of annular fissures. And then disc, in terms of radicular pain, disc extrusions, more severe stenosis and nerve compression are more likely to be symptomatic. And what we're looking for is a concordance of the pain syndrome and imaging to help suggest causation. So if you're not getting that information from the referring providers, giving a questionnaire or having somebody interview the patients to identify whether you're in the radicular category, which is actually kind of easier because if it's truly a radicular pain or sciatic pain, it's often some some cause of narrowing, whether it's a disc herniation, synovial cyst, or facet, or foraminal stenosis. The axial pain is much more elusive, but again, I don't think MRI is worthless in that regard because of the things that I discussed. And as a final note, to make a plug for doing our fluid-sensitive sequences, such as a stir, and ideally, if you have a 3D sequence available, you can generate almost a neurography type images. So we can see in this person who presented with a lumbar plexopathy and femoral nerve involvement, they have a disc herniation here shown in figure A with the arrows pointing to it. You can also identify denervation effect in the paraspinal muscles. So the arrowhead in A is pointing to the part of the multifidus muscle that's being denervated because of compromise to the medial branch. And then in B, we now have done MPR reconstruction, and we can see this area of hyperintense L3 nerve. Some people use the term radiculitis. I'm not sure that that's the most appropriate term. We tend to shy away from it because it's not really inflammation in the nerve. So we're kind of stuck with, L3 nerve that's showing abnormal signal, stir hyperintensity, often may be swollen or enlarged compared to the contralateral side. So in summary, MRI can show a high prevalence of non-symptomatic or degenerative, so-called maturational findings. We get wrinkles in our skin, we get wrinkles in our discs. MRI can show features relevant to the clinical context. Again, characterizing what the pain pattern is and imaging patients that are symptomatic, not using MRI as a screening exam. The significance depends on the concordance. So it really is important for the imager to know what the clinical context is, what the pain and dysfunction syndrome, whether it's given to you from the provider or through some questionnaire. Routine MRI may be insensitive to dynamic lesions. So combining reading MRI with upright radiography, if you have that in your packs, I think makes it more informative and makes you more useful. And then, for acute back pain, no imaging is indicated unless there's these red flag conditions. Lots of people have helped, contribute to my thinking and to this talk, and I wanted to acknowledge them. And I want to thank everybody for their attention. Q&A. Yep. Okay. See, there's 13 things listed here.
Mm-hmm.
Okay. So I'll just go from beginning to end. Is that okay, or should we? Then you let me know when.
Yeah. No, that sounds good.
Okay. Okay. So one question is stating, thanks for lecture, role of in and out of phase imaging in spine imaging. Is it reliable for you? Sorry, that wasn't the first question, second one, but I'll take that one. So yeah, I like in and out of phase. I like in and out of phase imaging for marrow solving problems. It's done as a gradient sequence. It takes less than 2 minutes. Some places I practice have used it routinely, but I think that and you do it as a sagittal image, and I think it helps you not have to bring somebody back for a little ditzel or something that is maybe an atypical hemangioma, because once in a while you do bring them back. So I'm a fan of a post-phase imaging. It's very quick, and do it in the sagittal plane, and it'll be a problem solver. Okay, so the first question is, I commonly see small facet joint effusions. Can these be considered normal, or is they always considered pathologic? Yeah, so small effusions, I think, are a sign that the facet is a bit irritated, but I don't think it necessarily means that they're symptomatic. So I'll mention them if, like, I'm more of the person, I mention a lot of things in the body of the report, but then when I go to the impression, I only put there what I'm impressed with, right? So what I'm impressed, or what I consider as a conclusion or a synthesis of what I see. But small facet joint effusions by themselves are really not significant. Okay, please explain the traversing the exiting nerve roots and their importance. Yeah, sorry. So when you do spine imaging, let's say you're at the L3, L4 motion segment. So in the lumbar spine, L3 will be exiting at that, and there's some nice diagrams that I don't have in this talk, but if you pull them up from the nomenclature that you can get from the ASSR website, the exiting nerve root is the nerve root that's coming out through the foramen. So at L3, L4, that would be L3. The rest of the nerve rootlets, so while they're still in the thecal sac, they're still rootlets. You can have 4 to 8 rootlets. You can have 4 to 8 rootlets make a nerve, and they don't have to necessarily be symmetric. But then the traversing nerves or traversing nerve rootlets are the ones that are going down there. So the importance of this concept is that, again, if we take L3, L4, if there is a disc herniation that's more central or in the subarticular zone, it's more likely to get the traversing nerve rootlets, and most likely to get L4, because L4 is the next one that's coming out, which will be right there in the subarticular zone. Whereas the exiting nerve is L3. That is if you have more of a foraminal disc herniation, or extraforaminal, so-called far lateral disc herniation, then it's going to get the exiting nerve. Annular fissures, can these be secondary to trauma? So yes, I think of it as a trauma of life. So we typically see them posteriorly. The spine gets injured in flexion, right? We bend over and do things, or maybe in bad body mechanics or ergonomics. And so when you do that flexion to the spine, you probably are ripping some of the annular fibers posteriorly. Again, can it occur from overt trauma? Possibly you bend over, you twist, you go to grab a 50-pound tire, if you're working or something like that, and these things can happen. In terms of medical legal implications, I think it's a real challenge to know, but so they're considered, I think, both degenerative and traumatic. Next question, is it okay to describe mixed types of modic? Yes, yeah. They can occur, you see type 1 and type 2 and type 3 together, or type 1, type 2, and type 3. It gets a little tedious, so you may just want to go with the dominant one and just say, there's some end plate signal alteration. The dominant one is edema or fat, or mixed edema and fat. And again, that helps you up your ante that disc is painful, particularly when they're sizable, like we talked about. Mixed types at any one level? No, they can occur, variety of levels. They tend to occur more likely in the lower segments. Next question, any clues for differentiating a traumatic herniation from degenerative herniation? No, I think unless you have an MRI right before the trauma and then one right after the trauma, It's hard to tell. I mean, seeing bright signal or soft tissue edema around it, I think, is also are challenging features. So what you can't say, I think, you can't exclude that a disc herniation was traumatic. So if somebody's asking you, say, well, this is a disc herniation, it's got to be degenerative, doesn't it? Well, most likely it is. I mean, it's degenerative. But if I had trauma, and and we all of us have those anecdotes of we are on the train and you grab your bag wrong and you twist and you've herniated a disc, so you've had some type of trauma there. So in general, the answer is no, but you can't. I would frame it as you cannot exclude trauma as being the etiology for disc herniation. ACR bulletin about disc disease stated the following. So putting this in the report, the following findings are so common in people without low back pain that while we report their presence, they must be interpreted with caution in the context of the clinical situation. So yes, so basically what this ACR bulletin is stating is, so if you were to do a lab test, and I'm not saying that MRI interpretation is a lot more complicated than a lab test, but you would have a calcium range, right? So basically what people are advocating is you sometimes put a range in your MRI. What I prefer to do is describe it as these multi-level spondylosis, and then in the impression I only include things that I think are likely to be symptomatic. But I think that the other concept is good too. Could you explain the toothpaste sign again? So I guess it depends if one uses tubes of toothpaste anymore, or if they use them out of a thing. I think it's not really that important. So rather than try to confuse people with explaining it, I would just ignore it, and I'm sorry about that. Do you use mild, moderate, and severe when describing foraminal or canal stenosis? And if so, what does it mean for you? Yeah, so it's a little bit different topic, but there is some great papers on looking at stenosis. So the lumbar spine stenosis group out of Zurich, which I had been part of, has published some nice things. That the most accurate thing is to measure the cross-sectional area of the thecal sac, and there are certain numbers that help you tell what is a severe stenosis. I don't measure it, but some colleagues in my practice do measure the thecal sac. So when you want to use mild, moderate, and severe, basically you separate it into 1/3 of what it should be. So mild is 1/3 narrowing of either the foramen or the central canal or subarticular zone than what you think it should be. Moderate is 1/3 to 2/3, and severe is greater than 2/3. So in terms of an anchor point, when there is complete effacement of the cerebral spinal fluid from the traversing nerve rootlets in the thecal sac, most surgeons and other folks would call that severe. Because moderate is such a broad category, I'll also separate it into mild/moderate and moderate/severe. So again, breaking it into fifths or tertiles instead of thirds, but it's really kind of semi qualitative, and that's true for the lumbar spine. Yeah, cervical spine is a little different. You can use the numbers there. What type of cases do you call a spine surgeon for decompression? Yeah, so we don't, call unless we don't call unless it's done as an emergent exam or something like that. So we don't tell the surgeons what to do. Again, imaging supports their diagnosis, but if somebody's coming in for for Carrino syndrome or something like that, I mean that's more of like a critical value or significant value kind of question. So in general, you can have a humongous disc herniation, but that doesn't mean that they're going to need to have a decompression. So I guess to answer that question, it depends on their clinical context. If they're coming in for like Carrino or new neurologic deficit, then we would call them. Next question, can isolated ligamentum flavum hypertrophy cause significant low back pain? Not that I'm aware of, and it's the ligamentum flavum doesn't, I mean, it gets thickened, it probably becomes redundant because you lose disc height, and so it looks hypertrophic, and it may get some thickening to it, but it's usually part and parcel of stenosis and neurogenic claudication. Next question, any thoughts on Bertolotti syndrome with transitional vertebra? So Bertolotti syndrome is the clinical manifestation of somebody who has a unbalanced transitional vertebra. So there's lots and lots of, well, there's many different classifications for transitional vertebra, but if you have one that's let's say that's unbalanced, where one side has what would be called a pseudo articulation, though some people don't like that term, but they have an extra, basically one side, the transverse process is enlarged and it's articulating with the superior sacrum and it looks degenerated. And the person has unilateral back pain or has back pain that's off to that side, then that's when you make the diagnosis of Bertolotti syndrome. Transitional anatomy is very common, 12 to 20%. You should mention it, but in terms of implicating it for pain, it's really hard unless you have the condition that I just described. How do you differentiate between discitis and modic lesions? Yeah, so discitis is so infection starts in the end plate typically, unless it's related to a needle procedure. So if you catch infection early enough, you may have a challenge from modic 1 and seeing osteomyelitis. However, by the time they usually present for imaging, there is some purulent material in the disc. This purulent material is bright as opposed to degenerated disc. So modic lesions are abutting a degenerated disc. The disc will have decreased signal. The caveat here is that vacuum phenomena can be bright on T2. So again, it's worth it to have a radiograph. So a degenerative disc is often dark, but sometimes can be bright if you have a vacuum or gas in there. Next question is, what about postoperative disc lesions? That's a whole another lecture. We can maybe try to think about that. And it's just a very general question. I'm sorry, I don't have a single answer for that. Next is, do you find any relevance for weight bearing or standing MRI plus or minus phalange extension position utilizing phonar scanners? Yeah, so I looked at this, and there is a AHRQ technology assessment that came out a number of years ago. It's a bit old, but the issue is that, and I've worked at places where they have load-bearing MRI. I think if you look at all comers for people who get imaged with MRI, it's a very small proportion where the load-bearing one is going to make a difference. So that's why I like having the upright radiograph. So of all the MRIs that I'll be reading, it'll just be a small percentage where I have that upright radiograph where I can make that call. The upright MRIs, the trade-off is sometimes in image quality. They tend to be midfield magnets, 0.5 Tesla. So then if you're trying to improve your image quality, your acquisition time is longer. It's actually hard to stand or sit still for a while. Everybody has sway, as I'm told from our biomechanics lab. And so I think sway plays into a factor of that. So I think, the current install base of MRIs, where you're doing it for spines and brains and knees and all other stuff, outweighs kind of having a specialized unit for that. Next, I've heard from a surgeon that prominent facet joint fluid indicates some instability. Have you heard that? I see above that you said the effusions are insignificant. Right. So a small effusion, so if the joint is coapted, if the joint space is normal or narrowed, and there's a small effusion, what that surgeon is talking about was the case that I showed with the facet joint being wider than expected. So when you see when you see the opposing surfaces are much wider, let's see if I can find it. Is my screen still projecting?
Yes, it is.
Okay, so can you see this image here?
Mm-hmm. Yes.
Yeah, so that degree would suggest that that is wider than normal. So that's not a small effusion. So I wouldn't categorize that as a small, like a drop of fluid. So that one, when you see this, I agree with the surgeon. This does indicate that there's some instability, often demonstrated on an upright radiograph, as you see in the next image here. Okay, what about caudal regression syndrome? Yeah, so that's I work as a musculoskeletal radiologist. So Usually that's in the neuro realm, and I'm not as familiar with that and be able to speak too much about caudal regression syndrome, other than that the spinal cord terminus looks very funny and blunted in an abnormal position. Can epidural lipomatosis be a cause for radicular pain? I think epidural lipomatosis can contribute to spinal stenosis, because anything that compresses the thecal sac, and in some people with spinal stenosis, they will have a polyradiculopathy. So, so I think epidural lipomatosis can contribute to spinal stenosis. Again, the definition is there's not a standard definition, but if you see fat that's uplifting the ligamentum flavum, and I don't have any pictures in this talk on that, if you see it uplifting the ligamentum flavum, then you can say there's epidural lipomatosis, but I don't think it affects the foramen as much. It's more of a central canal thing, is my take on it, but I don't have any studies or stuff to prove it. How long do annular fissures remain bright at MRI? I don't know, but I do know that they can wax and wane, so they can come and go. It's just like a meniscal tear. I mean, if you have enough space for the fluid, for the H2O molecules to tumble over each other, then you'll be able to see that. But they do come and go. So we'll see them in some people years, still there. Sometimes look new, sometimes look old. Next is, how can differentiate modic lesion simulates infective discitis? So we answered that question already. Next is, when do you consider contrast? So we consider contrast for a postoperative spine when they've had disc surgery within a couple years or so, because then it's really helpful to see enhancing versus non-enhancing tissue. In general, for infection and for tumor, you probably do not need contrast. How do I differentiate neurofibroma from a sequestered disc? Yeah, so a neurofibroma or peripheral nerve sheath tumor will often have a target sign. So this target sign or donut sign, if you look that up, can help you. The most common lesion, obviously, you're going to see in the canal is a sequestered disc. So odds are it's going to be a disc, but sometimes you can have peripheral nerve sheath tumors either in the foramen or in the thecal sac. What is the articular zone or subarticular zone? So again, I would refer you to the nomenclature document that's available on the ASNR, American Society of Neuroradiology website. And basically, the way to think about the subarticular zone is, if you're an anatomist or you're a surgeon and you're dissecting from the back into the canal, the zone underneath the facet articulation. So here we're seeing a facet joint, and I'm not sure if you can see my pointer or not. Probably not, but underneath the facet joint is known as the subarticular zone. It's sometimes synonymous with the lateral recess, but really not. The lateral recess is when you don't see the facet joint. But if you use the term lateral, if you think of the lateral recess, think of the subarticular zone as the part of the lateral recess where you see the facet joint on the images, is one good way to operationalize it, I think. How common is Bastrop syndrome? Well, we wrote a paper on it. So if you do PubMed search on Bastrop and Carrino, I think it's about 2 or 3% of seeing fluid, interspinous fluid. Does it cause low back pain? I think it doesn't by itself. It doesn't. It's not a dominant etiology for low back pain. It's often part and parcel of somebody who has a listhesis or hyperlordosis. If you inject that area, do you get some symptomatic relief? Yes, you can, but again, the placebo effect from injections can be up to 30%. So I see Bastrops as not often a dominant, or not often a significant or relevant finding for pain. If I see it, I'll mention it, because again, it can be part and parcel of their pain syndrome. Next is, why can vacuum phenomena be bright? The paper was by Mark Schweitzer a number of years ago, and I think they hypothesized that sometimes when you lay down, you can draw fluid in the disc, and that's why it looks bright. Or it just for some reason creates this bright signal on MRI. Bright on T2. I mean, sometimes it does look dark. Sometimes it looks like gas or air in there, but I don't know the real answer to that. But I do know that it does happen. And then email address for further future questions. I think you can reach me through the MRI online, folks. Is that right, Ryan? They can submit questions.
Yeah, yeah. If anybody wants to reach out to us, we can always get them in touch with you with your email address, of course.
Yeah.
All right. Well, it looks like those are all the questions. So as we bring this to a close, I want to thank Dr. Carrino for this lecture, and thanks to all of you for participating in our noon conference. A reminder that this conference is available on demand on MRIonline.com in addition to all previous noon conferences. Be sure to join us again on Monday for a lecture from Dr. Wang on breast MRI. You can register for that at MRIonline.com and follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again and have a great day.
Thank you all. Have a good day.